Exodeviations are classified into the following patterns. 1. Divergence excess exodeviation, in which the exodeviation is at least 15 degrees larger at distance than at near fixation. 2. Basic exodeviation, in which the distance deviation is approximately equal to the near deviation. 3. Convergence insufficiency exodeviation, in which the near deviation is at least 15 degrees greater than the distance deviation. 4. Simulated divergence excess exodeviation, in which the prism and cover test will show an exodeviation that is significantly larger at distance than at near fixation. However, by unilaterally occluding the eyes of such patients for 24 hours reveals the deviation at near fixation, often equal or even exceed that at distance fixation. This test is known as the occlusion test of Skibbereen. Patients with exophoria commonly complain of eye strain, blurring of vision, difficulties with prolonged periods of reading, headaches, and diplopia. Photophobia occurs commonly in intermittent exodeviations. It has been assumed that when a child is outdoors and looking at infinity, there are no near clues to stimulate convergence, and that bright sunlight dazzles the retinas so that fusion is somehow disrupted, causing the deviation to become manifest. These explanations imply that one eye is closed to avoid diplopia and visual confusion. Another less well-known symptom of intermittent exodeviations is micropsia. Young patients with an exodeviation may use voluntary convergence to overcome the deviation at near fixation. Therefore, it is advised to measure the angle of strabismus at distance while a patient reads the 6-9 line on the visual acuity chart. In patients with the divergence excess type of exodeviation, a latent strabismus at near fixation often coexists with a manifest strabismus at distance fixation. Thus, normal binocular vision is constantly being reinforced, and sensorial adaptations are infrequent. Consecutive exotropia arises either spontaneously in a formerly esotropic patient or iatrogenically after surgical overcorrection. Spontaneous change from esotropia to exotropia usually can be associated with poor vision of the deviating eye. Sensory exotropia is a condition of unilateral divergence as a sequel to loss of vision or long-standing poor vision in one eye, which was caused by refractive errors, unilateral cataract, aphakia, and many retinal and optic nerve lesions. Infantile exotropia is a relatively rare disorder. Onset is before age 6 months, where patients are healthy with no evidence of systemic or ocular disease.